Welcome to the deep dive. We are jumping straight into a stack of your notes and review materials today,
Excellent.
all focusing on, essential concepts in maternal health, specifically around labor and delivery.
That's right. And think of this as your guided tour through this critical information.
Yeah.
Our goal is really to help you quickly grasp the important aspects like how we monitor mom and baby, potential challenges, what actions get taken.
Do you feel well informed, but not totally overwhelmed by all the details?
Exactly. We're here to help you understand not just what the key facts are, but really why they matter.
Let's unpack this area. It's fascinating stuff.
Absolutely. Let's dive in.
Okay, so a huge focus during labor is obviously on the baby. And the main window we have into how the baby's doing is monitoring the fetal heart rate, or FHR. Why is paying such close attention to that FHR so critical?
Because the FHR tracing, it tells us how the baby is tolerating the significant stress of labor contractions.
Right.
Each contraction, it temporarily reduces blood flow to the placenta.
Yeah.
So the baby's heart rate response, that tells us if they're managing that stress okay.
It's like the baby communicating with us.
Essentially, yes. It's how they tell us how they're doing.
And your notes give us a baseline, right, for what's considered normal.
Yes. The typical baseline FHR is between 110 and 160 beats per minute.
Okay.
When you see a baseline in that range, plus, good variability of those little normal ups and downs and no concerning decelerations, that's usually category 1.
Healthy sign.
That's healthy sign, yeah. Typically no intervention needed just based on that FHR pattern.
But it's the deviations where we get the real insights. So what if the heart rate is consistently low, below 110? Bradycardia, what's going on there?
Bradycardia can signal potential issues. Things like placental insufficiency, maybe not enough oxygen getting to the baby.
Okay.
Or it could even be a side effect from certain pain medications, especially if they cross over to the baby.
And if you see bradycardia, the materials give us that action plan. Rodi. Can you walk us through that?
Yeah, that mnemonic from your notes is key. Reposition the mother, often onto her side, helps improve blood flow.
Okay.
Give oxygen. Alert the healthcare provider immediately. Discontinue oxytocin if it's running.
Because that increases contractions.
Right. It can worsen contractions and reduce that blood flow further and increase total fluids to boost maternal blood volume.
Got it. Rode. So bradycardia is low. What about high? Tachycardia above 160 BPM. What does that usually indicate?
Tachycardia in the baby can signal distress too. Causes listed in the sources include things like maternal fever or infection.
Oh.
The baby's heart rate goes up as the mother's body temperature rises. Could also be fetal trauma, mom being dehydrated, or even maternal use of stimulants.
So the immediate steps if you see tachycardia.
First thing, check mom's temperature. See if there are signs of infection. Then, oxygen for the mother, give IV fluids.
Right.
And if she does have a fever, an antipyretic to bring her temperature down.
Beyond just the baseline number, the sources really emphasize variability. What exactly are we looking at when we talk about FHR variability?
Variability is the fluctuation in the heart rate tracing around the baseline. It's not supposed to be a perfectly flat line. There are these tiny, normal ups and downs.
Okay.
This shows that the baby's autonomic demerbic nervous system, the part controlling heart rate, breathing, that stuff is healthy, mature, and, importantly, responsive.
And the notes highlight absent variability as a major red flag. Why is that so critical?
Absent variability means those normal fluctuations are essentially gone, undetectable.
Uh-oh.
Yeah. If the baby's nervous system isn't causing those tiny variations, it strongly suggests severe distress or a lack of oxygenation getting to the brain.
And this is where the FHR tracing categories come in, right? Absent variability immediately puts you in a Category 3 tracing, which your sources call an emergency.
Yeah, Category 3 tracings are defined by that absent variability plus things like recurrent late decelerations, recurrent variable decelerations, or bradycardia.
Or just absent variability with any decel.
Right. Or even just absent variability with any type of deceleration. These patterns strongly suggest the baby isn't getting enough oxygen. High risk.
And the intervention for Category 3 is pretty decisive.
Yes. According to these materials, a Category 3 tracing needs immediate intervention. Often means an emergency C-section to get the baby delivered quickly.
So Category 1 is normal. Category 3 is the emergency zone. What defines that middle ground? Category 2, the indeterminate space.
Category 2 is, well, it's everything else. It doesn't meet the strict criteria for Category 1 or 3.
Okay.
The sources mention it might include a baseline that's tachycardic or bradycardic, but crucially with some variability, not absent.
Right.
Or specific patterns like, say, prolonged decelerations but without accelerations. It basically requires continued watching, evaluation, but isn't immediately screaming severe distress like Category 3.
And the intervention often starts simpler, like just repositioning the mom, as listed for Category 2.
Yes. Often simple measures like changing her position are tried first, while you keep monitoring really closely.
Okay, let's dig a bit deeper into those dips you mentioned, decelerations. What are these drops in heart rate telling us, and how do the different types signal different things?
Decelerations are really key signals. The sources break them down based on when they happen relative to a contraction.
Makes sense. First up, early decelerations.
Early decels are these symmetrical dips in the FHR that basically mirror the contraction. They start and end roughly at the same time as the contraction.
And the cause.
Your notes say head compression. As the baby moves down, the head gets squeezed a bit. It's like a natural vagal nerve response.
They're not usually a worry.
Generally considered benign, expected. So the action is typically just continue to monitor.
Okay, so early decels are usually fine. What about late decelerations, the ones that happen after the contraction peaks?
Late decels are much more concerning. They start after the contraction has peaked. The sources are clear. This pattern signals hypoxia. The baby isn't getting enough oxygen. The underlying cause is often placental insufficiency. The placenta just isn't transferring oxygen effectively during that contraction stress.
And this is where flip, drip, sniff comes back in. Same actions as for bradycardia plus readiness for a C-section.
Exactly the same. Flip the mom's position to try and optimize blood flow, drip in more IV fluids, sniff with oxygen via mask, and definitely be ready for a potential urgent delivery because of that oxygen concern.
Gotcha. Okay, third type, variable decelerations, described as sharp V or W-shaped dips. Quick down, quick return.
Variable decels are often the most common type you'll see, and they signal cord compression.
The umbilical cord getting squeezed.
Right. The cord might be wrapped around the baby or maybe caught between the baby and the pelvis. That squeeze temporarily reduces blood flow.
And the action for variable decels, similar to Lenarthate's.
Yes, the initial actions are the same. Flip, drip, sniff. Repositioning the mom is often really effective here because it can shift the baby off the cord. Oxygen and fluids are supportive too.
Finally, prolonged decelerations. What makes these different?
A prolonged decel is any deceleration that lasts for at least 2 minutes, but importantly, less than 10 minutes.
Why less than 10?
Because if it goes on for longer than 10 minutes, it's considered a change in the baseline, usually to bradycardia.
Ah, okay. And the causes for prolonged?
Can be things like poor perfusion to the placenta, really poor umbilical blood flow from severe compression, or sometimes strong vagal stimulation in the baby.
And interventions mirror the others again?
Yes. Flip, drip, sniff are your immediate go-to steps to try and fix whatever's causing it. And you're definitely thinking about the potential need for a C-section if it doesn't resolve quickly.
It's actually really insightful seeing how those different shapes and timings on the tracing directly point to different issues. Head compression versus placental problems versus the cord.
It really is. It's like the baby's using this specific language to tell us what's happening. Understanding the connection is crucial.
Definitely more helpful than just memorizing patterns. Okay, let's shift focus a bit to getting prepared for birth. What are some essential assessments and preparations highlighted in your materials?
Well, a really common scenario is needing to confirm if the mother's waters have broken, the rupture of membranes. It's not always a big gush. Sometimes it's subtle.
And your notes prioritize one specific action when the waters might have broken or definitely have. What's the first thing?
The very first thing you do is assess the FHR. Always check the baby first.
Why first?
Because when a membrane's rupture, there's a risk, albeit small, that the umbilical cord could prolapse, slip down, and get compressed as the fluid rushes out. So checking the baby's heart rate immediately is vital.
Okay, check baby first. Then the sources list several ways to confirm if it is amniotic fluid, right?
Yes, there are tests like the nitrazine test, which checks the pH amniotic fluid is more alkaline. You can look for ferning patterns under a microscope when the fluid dries on a slide. There are also specific commercial tests like Amnisure, or a provider might do a speculum exam to actually see fluid leaking from the cervix.
Another big preparation area involves the cervix itself. Is it ready for labor? The Bishop score comes up here.
Right. The Bishop score is a system used to evaluate the cervix's readiness for labor induction. It looks at several factors: dilation, effacement or thinning, consistency, its position, and the baby's station, or how far down it is.
And what score does the source say indicates a good likelihood that the cervix will respond well to induction medication? like oxytocin.
A score of 7 or higher suggests a favorable cervix for induction. If the score is lower than 7, the notes indicate you'd likely notify the healthcare provider.
And they might consider ripening first.
Exactly. They might decide to use a cervical ripening agent first to help soften and open the cervix before starting induction meds.
What are some examples of those ripening agents listed?
Medications like Cervidil, which is a vaginal insert, or Cytotec, also known as misoprostol. Or they might use mechanical methods like inserting balloon catheters or Foley catheters into the cervix to help it dilate passively.
Your notes also specify criteria that have to be met before doing an amniotomy, artificially breaking the water with that little hook.
Yes, safety first. The cervix needs to be dilated enough to safely insert fingers, usually at least 2 centimeters.
Right.
And importantly, the baby's head must be well engaged down in the pelvis, not floating high up or palatable.
To minimize that cord prolapse risk again.
Precisely. Don't want the cord washing out ahead of the baby.
Before labor gets too intense, figuring out the baby's position can be really helpful. That's where Leopold's maneuvers come in, right?
Yep, Leopold's maneuvers. It's a systematic way of feeling the mother's abdomen, palpating different areas, to determine the baby's lie, are they lengthwise or sideways. Presentation head first, bottom first, and position.
Okay.
You feel for the baby's back, the head, the bottom. Helps paint a picture.
And there's a practical tip in the notes related to Leopold's and FHR.
Yeah, it's a good clue. If you perform Leopold's and then you listen for the fetal heart tones and you consistently hear them above the mother's umbilicus, her belly button, it should make you think the baby might be in a breech presentation, so bottom or feet first instead of the usual head-down position.
Good clinical pearl. Okay, leading up to labor, moms often notice physiological changes. What are some classic signs of impending labor your notes mention?
Some common signs include changes in vaginal discharge, like losing the mucus plug, sometimes called the bloody show.
Right.
The baby dropping lower into the pelvis. This is called lightening. It can actually make it easier for mom to breathe.
But more pelvic pressure.
Exactly.
Yeah.
More pressure down below, maybe more frequent urination. And sometimes women get that sudden burst of energy called nesting syndrome, wanting to clean and organize everything.
But sometimes these signs can be confusing, leading to false labor. How do the sources differentiate false labor from true labor?
False labor can feel pretty real. You might have symptoms like back pain and contractions often called Braxton Hicks.
Okay.
But the key difference is that false labor contractions are typically irregular. They don't get stronger, longer, and closer together in a predictable pattern.
And the biggest difference?
Most importantly, they do not cause any change in the cervix. No dilation, no effacement. True labor causes progressive cervical change. That's the real marker.
That cervical change is the definitive sign. Okay, let's talk about the journey through labor itself. Your notes use a helpful framework. The 5 Ps of labor.
Right. This framework helps organize thinking about all the factors that influence how labor progresses. The 5 Ps are powers.
The contractions.
Yeah, the strength, frequency, duration of uterine contractions. Then passage the mother's pelvis, the birth canal shape and size.
Okay.
Passenger, that's the baby. Its size, position, presentation. Psych, the mother's psychological state, how she's coping, fear, anxiety levels.
That makes a difference.
It really can. And finally, position the mother's position during labor. Moving around can impact comfort and help the baby descend.
Pain management is obviously a huge part of labor. What non-pharmacological options are listed before moving to medications? Things to try first.
The sources mention several techniques, focusing on breathing exercises, using distraction music, imagery, walking and movement, changing positions frequently, using counter pressure, especially for back labor, applying firm pressure to the lower back, and effleurage, that light, rhythmic stroking on the abdomen.
If those aren't quite cutting it, pharmacological options are considered. Nitrous oxide is one mentioned. Key points about that.
Nitrous oxide, or laughing gas. Side effects can include feeling lightheaded, dizzy, maybe some nausea or vomiting, drowsiness.
And how is it used?
The notes say you typically instruct the mother to start inhaling at about 30 seconds before a contraction is expected to peak. That way, the analgesic effect is strongest during the most intense part. She holds the mass herself.
And the sources mention something important about FHR after pain medication is given. Not just nitrous, but systemic meds, too.
Yes. It's noted that after systemic pain medication is administered like opioids, you might see a decrease in FHR variability.
Yeah.
Sometimes minimal, maybe even transiently absent variability.
Why does that happen?
Because the medication crosses the placenta and affects the baby's central nervous system, just like it does the mother's. It's an expected effect, but still requires close monitoring.
Epidurals are very common. What are the key nursing responsibilities before an epidural is placed, according to the notes? Big checklist here.
Absolutely. Before the anesthesiologist comes, you need to assess the FHR baseline. Ensure the mother has good IV access, usually a large bore IV. Check and document her baseline vital signs, especially blood pressure.
Because it can drop BP.
Exactly. Hypotension is a common side effect. That's why you administer a bolus of IV fluids beforehand, usually 500 to 1,000 millimol, to help counteract that potential drop. And make sure she empties her bladder right before because she won't feel the urge to pee afterwards.
Makes sense. Okay, medical management often involves oxytocin or pitocin to stimulate or strengthen contractions. What's the nursing checklist before starting oxytocin?
Before initiating oxytocin, the sources say you need to check a few things. Cervical consistency, confirm the presenting part of the baby, review the Bishop score for readiness, and of course verify the physician's order.
A potential complication or side effect of oxytocin is tachysystole. What is that, and why is it concerning?
Tachysystole basically means excessive uterine activity. The contractions are happening too frequently, maybe more than 5 in a 10-minute period, or they're lasting too long, or there isn't enough rest time for the uterus to relax between them.
And why is that bad?
It's concerning because that reduced rest time between contractions means less time for blood flow and oxygen exchange between the placenta and the baby. It can stress the baby.
And the actions if you see tachysystole.
The steps listed include changing the mother's position, making sure she's well hydrated, maybe giving an IV fluid bolus, potentially decreasing or stopping the oxytocin infusion completely, and if needed, administering a tocolytic medication like terbutaline.
To relax the uterus.
Exactly. To calm down those contractions.
Sometimes a little extra help is needed right at the end for delivery. The sources mention operative vaginal delivery using a vacuum assist or forceps. If these tools are used, does the mother still need to push?
Yes, absolutely. The mother is still instructed to push during contractions to assist the delivery. The instruments provide traction to help guide the baby out, but they don't replace her pushing effort entirely.
And there's a specific rule mentioned with the vacuum, the 3-pull rule. Why is that guideline in the sources? What are the risks?
Using the vacuum involves applying suction to the baby's head and then traction. Limiting the number of attempts, like the 3-pull rule, or setting a time limit, often 15-20 minutes, is important because excessive force or prolonged use increases risks.
Risks for the baby.
For the baby, risks include things like cephalohematoma. That's a collection of blood under the scalp, potential for intracranial hemorrhage or brain bleeds, and jaundice.
And for the mom.
For the mother, risks include vaginal or perineal lacerations and potential hemorrhage. So limiting attempts minimizes those risks.
Your notes also describe a recommended pushing technique, open glottis pushing. What does that actually mean?
Open glottis pushing is basically pushing when you feel the natural urge to push. That's often called the Ferguson reflex. It involves pushing while allowing some air to be expelled, like groaning or breathing out during the push.
As opposed to
holding your breath, bearing down really hard against the closed glottis that's closed glottis pushing. Open glottis pushing is thought to be less stressful for mom and baby, potentially improving oxygen flow and reducing maternal fatigue.
Interesting. Finally, a key term for cracking labor progress is fetal station. What does station refer to?
Fetal station describes how far down the baby's presenting part, usually the head, has descended into the mother's pelvis. It's measured in relation to the ischial spines, which are bony landmarks in the pelvis.
Okay.
Minus numbers, like -3, -2, -1, mean the baby's head is still above those spines, higher up.
Yep.
Station 0 means the head is right at the level of the spines.
And plus numbers.
Plus numbers, +1, +2, +3, mean the baby has descended past the ischial spines and is getting closer to delivery. +3 or +4 is often when the head is crowning.
Okay, so we've walked through the typical labor process and interventions, but things don't always go smoothly. Your sources cover a range of potential complications and emergencies.
Yes, unfortunately. Seeing meconium-stained amniotic fluid is one of those things that can raise concern. That's when the baby passes their first stool, meconium, while still inside the uterus.
And it stains the fluid green or brownish?
Exactly.
What's the immediate action when you see that?
Immediately notify the healthcare provider, and importantly, alert the neonatal team pediatrician or neonatal nurse practitioner so they can be present at the delivery. The notes also emphasize listening closely to the baby's heart tones during pushing.
And why is meconium-stained fluid a concern for the baby? What's the risk?
The greatest risk for the neonate is meconium aspiration syndrome, or MAS. If the baby inhales that sick meconium into their lungs, Either before, during, or right after birth, it can cause severe respiratory distress. It can be life-threatening. Another broad complication mentioned is labor dystocia.
Your notes define that as failure to progress in labor, like labor just stalls out. What are some risk factors listed for this happening?
Factors that increase the risk include having a history of dystocia in a previous pregnancy, being a first-time mother, nulliparity, the baby being in a tricky position like breech or shoulder presentation.
Malpresentation.
Right. Also, if the baby's very large, macrosomia. Getting anesthesia too early in labor, maternal fatigue or dehydration, significant maternal fear and anxiety.
The psych P again?
Exactly. Or a true physical issue like cephalopelvic disproportion CPD, where the baby's head is just too large to fit through the mother's pelvis.
What about shoulder dystocia? That sounds specific and scary. When the baby's shoulder gets stuck.
It is an emergency. Shoulder dystocia happens when, after the baby's head is delivered, the anterior shoulder gets stuck behind the mother's pubic bone, preventing the rest of the body from being born.
And the greatest risk here?
Your sources highlight the greatest risk. Compression of the baby's neck by the pelvis. This can cut off oxygen, leading to fetal asphyxia, or cause nerve damage to the arm, like a brachial plexus injury. Requires immediate maneuvers to free the shoulder.
Another critical emergency is cord prolapse.
This is when the umbilical cord slips down ahead of the baby's presenting part after the membranes have ruptured.
So the cord comes out first?
Or lies below the presenting part. The danger is that it can then become compressed between the baby and the mother's pelvis, cutting off the baby's entire blood and oxygen supply. A true emergency.
What are the absolute immediate actions listed for a cord prolapse? What do you do right now?
The notes stressed immediate action. Call for help loud and clear. Stop any oxytocin infusion immediately. Prepare for an emergency C-section.
And critically,
you need to manually lift the baby's presenting part off the cord. Usually means inserting a sterile gloved hand into the vagina and physically holding the baby's head or bottom up away from the cord to relieve that compression.
And you keep doing that
until the C-section is performed. You might also place the mother in a Trendelenburg position, head down, or knee chest position to use gravity to help keep the baby off the cord.
Wow. Okay. Uterine rupture is another severe, life-threatening complication mentioned.
This is a partial or complete tear in the wall of the uterus. It most commonly happens at the site of a previous C-section scar, which is why TROC has specific criteria.
And the complications are severe for both.
Absolutely. For the mother, potential for massive internal bleeding leading to shock, infection, severe hemorrhage, hypovolemia. For the fetus, severe oxygen deprivation, asphyxia, often death is not delivered immediately.
And the interventions, similar emergency response.
Yes. Immediate actions are notifying the provider, getting really good IV access for fluids and potentially blood transfusion, positioning the mother laterally to optimize blood flow, and preparing for an immediate emergency C-section and possibly uterine repair or hysterectomy.
Wow.
Your notes also discuss preeclampsia in detail, that hypertensive disorder specific to pregnancy that affects multiple organ systems.
Right, not just high blood pressure. What are some of the serious complications it can progress to?
Preeclampsia can worsen significantly and lead to eclampsia, which is the onset of seizures.
Okay.
Other major complications include severe effects on the brain like cerebral edema, hemorrhage, or stroke, HELLP syndrome, that's hemolysis, elevated liver enzymes, low platelets, a very severe variant, heart failure, DIC.
That clotting disorder.
Yes. Disseminated intravascular coagulation, a serious bleeding and clotting disorder, and placental abruption, where the placenta separates prematurely. Really serious stuff.
And the list of risk factors for developing preeclampsia from your materials is quite extensive. Who is more likely to get it?
Yes, it includes being a first-time mother, nulliparity, age extremes, so under 20 or over 35, obesity, carrying multiples like twins or triplets, having a family history of preeclampsia.
Pre-existing conditions.
Definitely. Chronic medical conditions like high blood pressure before pregnancy, kidney disease, autoimmune diseases like lupus or diabetes. Also, having had preeclampsia or eclampsia in a previous pregnancy significantly increases the risk, and even having gestational diabetes in the current pregnancy is listed as a risk factor. Knowing these helps identify women who need closer monitoring.
Post-term pregnancy, going past 42 weeks, also brings specific risks according to the sources.
Yes, as the pregnancy continues beyond 42 weeks, the risk of stillbirth unfortunately increases. Other risks for the fetus include meconium aspiration, because they're more likely to pass meconium, and potential seizures.
And what about the placenta?
Your notes mentioned that the placenta begins to age, essentially. It starts calcifying after 40 weeks, becoming less efficient at providing the necessary oxygen and nutrients to the baby.
Chorioamnionitis is another infection listed. Infection of.
Infection of the amniotic fluid, the membrane surrounding the baby, and sometimes the placenta itself, often called chorio.
What are the signs and symptoms to look for?
Key signs include foul-smelling, cloudy, or sometimes yellowish amniotic fluid discharge, maternal fever, fetal tachycardia heart rate consistently over 160 for 10 minutes or more, and an elevated maternal white blood cell count, often noted as above 15,000.
And the risks associated with chorioamnionitis. Why is it bad?
Risks include prolonged rupture of membranes being a cause, but also chorio itself increases risk for maternal or fetal sepsis, prolonged labor, postpartum wound infections after C-section, potentially needing a hysterectomy in severe cases, and postpartum complications like endometritis infection of the uterine lining and postpartum hemorrhage.
Finally, under emergencies, anaphylactic syndrome, often called amniotic fluid embolism or AFE, listed as an absolute emergency.
It is. AFE is a rare but absolutely catastrophic event. It happens when amniotic fluid, fetal cells, hair, or other debris enters the mother's bloodstream, triggering a massive, sudden allergic-like reaction.
And the signs are sudden and severe.
Yes, typically sudden onset of severe respiratory distress, shortness of breath, gasping, and rapid development of cardiovascular collapse and DIC, that's severe bleeding disorder, high mortality rate.
And immediate action is critical for any chance of survival.
Absolutely critical. The notes specify immediate actions: providing high-flow oxygen, intubation likely needed, establishing large-bore IV access, preparing for massive transfusion with blood products to manage the DIC, stopping any oxytocin infusion immediately, and performing an emergency C-section to deliver the baby, often concurrently with resuscitation efforts.
Phew. Okay, that's a heavy list of potential complications, really highlighting how dynamic and, frankly, risky labor can be. Let's shift gears slightly to cesarean birth. For a scheduled C-section, what are the essential preoperative steps listed in your notes?
Right, for a planned C-section before going to the OR, the steps include checking the FHR one last time to confirm fetal well-being, assessing the mother, getting baseline vital signs, ensuring she has that IV line established.
The fluid bolus again?
Yet giving an IV fluid bolus before going to the operating room to prevent hypotension from the spinal or epidural anesthesia. Administering prophylactic antibiotics, usually within an hour before incision, to prevent infection. And giving an oral antacid like sodium citrate to neutralize stomach acids and reduce the risk of aspiration if she were to vomit.
What key information should be included in patient education for someone having a C-section? What should they know about recovery?
Patients should be informed that the IV line will stay in for a while after surgery for fluids and meds. They'll likely receive IV medication for nausea, like Zofran, as needed. They'll continue receiving antibiotics for a period. They'll need sequential compression devices, SCDs, on their legs, those inflatable sleeves to help prevent blood clots. Nurses will regularly assess their uterine fundus for firmness and check their vaginal bleeding, the lochia. And their vital signs will be monitored very frequently in the initial recovery period.
And for discharge teaching after a C-section, what are the most important points to cover before they go home?
Key points include activity restrictions, usually avoiding lifting anything heavier than the baby for several weeks. Monitoring the incision closely for signs of infection. Increasing redness, pain, swelling, any drainage, or a fever, specifically noting 100.4 Fahrenheit or 38 Celsius.
Right.
Managing pain effectively with prescribed medication, emphasizing the importance of ambulation, getting up and walking to prevent blood clots and help recovery, educating them about screening for postpartum depression signs and symptoms, and crucially, teaching them the signs of postpartum hemorrhage to watch for at home.
Like what specifically?
Like passing blood clots larger than a fist or completely saturating a large sanitary pad in an hour or less, especially if it persists.
Yeah.
That needs immediate medical attention. Your materials also cover TOLAC, that's trial of labor after cesarean.
Right. Trying for a vaginal birth after having had a C-section previously. What are the criteria listed that make someone a potential candidate for TOLAC?
The main criteria include having had only one or possibly two prior C-sections, and crucially, those C-sections must have been the low transverse type incision on the uterus itself.
Not the skin incision, the uterine one.
Correct. That's the most important factor for uterine rupture risk. Also, no other significant uterine scars, like from fibroid removal. If attempting TULAC with twins or if inducing labor, some guidelines suggest needing 2 prior low transfer sections. The mother must have an adequate pelvis shape, clinically assessed, and, critically important,
Staff availability.
yes, a physician capable of performing an emergency C-section and an anesthesia team must be immediately available throughout the entire labor, just in case uterine rupture or another emergency occurs.
And what are the exclusions? The reasons someone would not be a good candidate for TLAC?
Exclusions mainly revolve around increased risk of uterine rupture. So having a prior vertical or classical uterine incision or a T-shaped incision, or having had other extensive uterine surgery, a history of a previous uterine rupture is an absolute contraindication. Known pelvic abnormalities that would prevent a vaginal birth. And, as mentioned, if the facility cannot provide that immediate emergency C-section capability, TULAC shouldn't be attempted. One final procedural step mentioned in the context of C-sections is the OR timeout.
Right, the timeout. What is that exactly, and what's its purpose?
The OR timeout is a mandatory safety step. It's performed just before the start of any surgical procedure, including C-sections. The entire surgical team, surgeon, anesthesia, nurses, techs, pauses together.
To do what?
To verbally confirm several key things. Correct patient identity, correct surgical site, correct procedure to be performed. Everyone has to agree. It's a crucial final check to prevent wrong site, wrong procedure, or wrong patient errors. Patient safety standard.
Makes total sense. Okay, we've covered a ton. Monitoring, prep, interventions, complications, C-sections. Let's quickly map some of this onto the traditional stages of labor framework and touch on immediate postpartum care.
Sounds good. Stage 1 is the longest stage, all about cervical dilation and effacement. It's divided into latent and active phases.
Latent stage 1 is early labor. Typically from 0 centimeter dilation up to about 4, maybe 6 centimeters. Contractions might be fairly mild, maybe 5-10 minutes apart, lasting 30-45 seconds. The sources mention maternal behaviors here might be more focused, inward thoughts about herself, the labor, the baby. She's often still coping relatively well, maybe excited or anxious.
Right. Then you transition into active stage 1. This is when labor really picks up pace.
Yeah.
Roughly from that 4 to 6 centimeter mark all the way to 10 centimeters fully dilated. Contractions get stronger, longer, maybe 45-60 seconds, and much closer together every few minutes.
And mom's behavior changes.
Often, yes. She might become more restless. Breathing becomes more labored. You might see increased fear or anxiety as the intensity really builds. Nursing responsibilities here include assessing FHR and contractions more frequently, typically every 15-30 minutes for a low-risk patient, and actively assisting with coping strategies like breathing techniques or position changes.
Stage 2 is the pushing stage. Starts when the cervix hits 10 centimeters, fully dilated, and ends when the baby is delivered.
Yep. The sources describe encouraging pushing techniques, like that open glottis pushing we talked about, pushing with the urge, maybe 3-4 times with each contraction for about 6-8 seconds, following the body's natural Ferguson reflex.
And maternal behaviors during pushing.
She might feel that overwhelming urge to push. It can be very focused, intense work. Interestingly, the notes mention she might even desire rest or sleep between contractions because it's so exhausting.
Best positions for pushing.
Often upright positions are helpful to utilize gravity, like elevating the head of the bed significantly or using a squatting bar. The sign that you've progressed from stage 1 to stage 2 is typically that involuntary, strong urge to push as the baby descends low enough.
Stage 3 is the shortest stage. Starts right after the baby's delivery and ends with the delivery of the placenta.
Right. And a key intervention here is often giving medication, usually oxytocin again, either IV or IM, right after the baby is born, but before the placenta is delivered.
Why then?
To help the uterus contract down firmly. This helps the placenta detach and significantly reduces the risk of postpartum hemorrhage. Maternal behaviors here can shift dramatically: relief, pride, overwhelming happiness, maybe very emotional, wanting to hold the baby.
And finally, stage 4, the immediate recovery period. Typically the first 1-2 hours right after delivery.
This is a really critical monitoring phase. Key nursing responsibilities include frequently checking the mother's vital signs, assessing her fundus, the top of the uterus, making sure it's firm, midline, and at the right location, usually near the umbilicus right after birth.
Yeah. Fundal massage if it's boggy.
Yes, performing fundal massage if it feels soft or boggy to help it contract. Monitoring her lochia, the vaginal bleeding, checking the color, amount, and presence of clots. Encouraging her to empty her bladder soon, because a full bladder can prevent the uterus from contracting properly. And managing her pain, whether from Deschers or the C-section.
And maternal behaviors in stage 4.
She might experience postpartum chills, which are common, often feels very hungry and thirsty, can feel drowsy or sleepy after the exertion. And of course, she'll be passing lochia. Bonding with the baby is key here too. And your notes also briefly touch on responsibilities during the difficult situation of a stillbirth, emphasizing providing compassionate support to the parents and encouraging them, if they wish, to hold their baby, create memories.
Wow. That was a truly comprehensive deep dive through your notes. We covered so many absolutely critical concepts of maternal health related to labor and delivery.
We really did. We worked our way through understanding the baby's heart tones, the signs of labor starting, navigating all the different interventions, potential complications, the stages, pulling out the core information from the material you provided.
Hopefully this has helped to clarify these complex topics for you, the listener, giving you that kind of shortcut to feeling well-informed.
Yeah.
Seeing how all these pieces fit together, from a subtle FHR change, maybe signaling just a need for repositioning, all the way to understanding the rapid cascade of events in a major complication like a cord prolapse. It really shows how dynamic and critical assessment is in this field.
It really emphasizes that every piece of information you gather, every assessment made, it directly informs the next decision, all aimed at ensuring the best possible outcome for both the mother and her baby.
What stands out to me listening back is how much understanding the why behind each action really reinforces the what. Like, understanding why absent variability is an emergency makes the need for immediate action, maybe a C-section, so much clearer than just memorizing absent variability bad.
Absolutely. Connecting the pattern you see, or the symptom, to the underlying physiology, that's the key to true clinical understanding, not just recall.
So maybe a final thought for you to mull over as you continue exploring this topic. How does integrating that why, the physiology, the mechanism, change the way you might approach assessing a situation in labor? Does understanding the why behind a late deceleration, for example, shift your immediate priority or your communication with the team?
That's the kind of reflective thinking that moves you beyond just knowing the facts to truly understanding the whole clinical picture, developing that intuition.
Keep asking those questions. Thanks so much for joining us for this deep dive.